Hi class, and welcome to Chapter 3 video lecture. In this video, I'll briefly be going over Chapter 3 that covers the evolution of health services in the United States. So my aim is to go over the main concepts covered. However, I try to keep in mind that I don't want this video lecture to get too long. So I do want to remind you that even though I'll be going over some areas of the chapter, I do expect you to read the full chapter and go through the PowerPoint presentation in its entirety. Now, when I've created these PowerPoint presentations for the chapters in this course, I included more detail than you would have in a usual PowerPoint presentation, so you could use it more as a study guide as well, along with what you've read in the chapter. All right, so let's get started here. So here are the learning objectives. And in this chapter, focus is really discussing and discovering historical developments that have shaped the U.S. healthcare delivery system, which will help you understand the history of mental health care in the U.S. We also cover why the system has been resistant to national insurance reforms. And we also cover the corporatization of healthcare, as well as globalization of healthcare, and the historical perspective that brought us to the Affordable Care Act. And we also cover the prospects of new healthcare reform efforts. So let's get started. So in the beginning, we're going to jump to, or actually begin with, medical services in the pre-industrial era. So something I'd like to keep in mind here is that America's history of healthcare is a bit different than most first world nations. Our belief in capitalism has really prevented us from developing the kind of national healthcare system that we've covered in Chapter 1 when we covered the UK or France or some of the European countries, as well as Canada. Now here we're going to go through how it really began. So when we talk about medical services in pre-industrial era, there were no health insurance to pay for professional services. The free market conditions prevailed. And here covers kind of the 5 factors why the medical profession remained an insignificant profession. So 1, the medical practice was in disarray. It was primitive. It was missing an institutional core. So medical practice was not connected with hospitals. Demand was unstable, and medical education was substandard. Now, regarding the practice of medicine in the pre-industrial era, there were really 4 main reasons why the practice of medicine in the U.S. during the pre-industrial era had a domestic rather than professional character. In rural and small-town communities, there was a strong orientation toward self-reliance. The family as the center of social and economic life was the natural locus of caring for the sick. Family care was supplemented with advice and assistance from kin and community, and by consultation of published medical guides. The market for physician services was limited by economic conditions. So for most people, the combined expense of the direct costs of the physician's fees, along with the indirect costs of transportation and the opportunity cost of travel, was excessive. The third reason was personal health services had to be purchased without the help of government or private insurance. Again, as we said, it was fee for service. There was often little that a physician could do for a patient that the patient's family could not do. So with the growth of urbanization, telephones and mechanized transportation reduced the cost of time and travel, making medical care more affordable for most people, increasing that access component that's kind of being addressed. And also with this move and this urbanization shift from rural areas, it really spread spread family members further. Women entered the workforce, so they really weren't able to care for the sick members of the family. So urbanization was a big reason that we saw this change happening in the area of medicine. So look at this table here. It kind of covers this evolution of what occurred in the mid-18th to late 19th century, and then the shift from the late 19th to the late 20th century really had a lot to do with the advancement in science and technology, which really increased the demand for medical services. So advances in bacteriology, antiseptic surgery, anesthesia, immunology, diagnostic techniques, and new drugs gave medicine an aura of legitimacy and complexity. So scientific medicine and technology really increased people's reliance on a physician's professional judgment. Lay people were no longer competent to provide medical care. Professional help was likely to do more for the patient than what folk remedies could do. So this is where a lot of it shifted. Really quick, even though this is covered in the slides to come, so what we saw in the mid-18th to the late 19th century, or this pre-industrial era, is it was open entry into medical practice. There was intense competition. It was very weak and unorganized. Apprenticeship training, so it wasn't a very organized type of training. Undeveloped hospitals. We had the almshouses and the pest houses, which we're going to be covering, I think, in the next slide. Mental asylums, private payment for services, low demands for services, and private medical schools providing only general education. And that's kind of how it evolved in the pre-industrial era, leading us to this development of science and technology. And that urbanization really kind of led to that shift that we saw in the late 19th to the late 20th century. And medicine became more specialized. There was licensing that was introduced. So the whole type of medical training was really reformed. The emergence of organized medicine again, the emergence of modern hospitals. So we had a lot of changing going on. And then ultimately, we have that last section here going into the late 20th to 21st century. So now I'm going to jump to slide 11, since we kind of went over what the pre-industrial era really, how medicine was during that era, and just to go through some of the examples of what we're talking about this unorganized type of medicine. So a barber sells herbal prescriptions in his shop. A woman gives birth at home with just the help of her sisters and her mother. A tailor who doubles as a doctor visits the home of a boy cut by a sharp rock and sews his wound. A church pools its funds to have a doctor visit its pastor who has been bedridden with a mysterious illness. So the doctor bleeds him and gives him herbal concoctions and enemas. So this is kind of just to give you an idea of when I say primitive medicine, what I mean. So now I wanted to jump to slide 15 and just go over this, what almshouses and pest houses were, which was kind of, I would say, the starting point for hospitals, but they were still not associated with or connected, I would say, with medicine yet. And they kind of evolved into our hospitals that we have today. So let me jump to 15. And these are really the precursors to hospitals. So an almshouse was a shelter for the poor offered by the government. The primary function was really food, housing, social welfare. And healthcare was very secondary. When residents got sick, it was addressed, but it was not the main function of what an almshouse was. Now, pest house, also operated by the government, it served more as a quarantine facility. when we're talking about contagious diseases like cholera, typhoid, smallpox. Now here I am on slide 18, looking at early hospitals, which really began to emerge in the 1850s. And the first such hospital was actually established in Pennsylvania, and then followed by another one in New York. And they really lacked resources. A lot of times they were referred to as poorhouses. They really had deplorable conditions, poor sanitation, inadequate ventilation, and unhygienic practices. And the mortality rate in both US and European hospitals in the 1870s was about 74%. So people really avoided hospitals unless they absolutely had to be there. I did want to point out, though, regarding the professionalism of medicine, it did start much later in the US in comparison to Western European nations. So advances in medical science, experimental research, and medical education in the US really lagged far behind when we compared it to Britain, France, Germany. And this was a major reason for the differences in the professionalism or professionalization of medicine between the US and the Western nations, or I should say the Western European nations. And next, I want to jump to slides 23 and 24, looking at pre-industrial medical school. So this was kind of the layout once it was introduced. It was 2 years, and you got an MD degree. And year one, you would attend 3 to 4 months of courses. Year two, repeat the same kind of idea, 3 to 4 months of courses, and ultimately you would graduate. Now, this is a big one. So there's a large part of this chapter that covers the transformation of medicine in the US. And there was a key number of contributors. First, urbanization, which we've already covered. Science and technology, we definitely touched on. Institutionalization, dependency is another one, cohesiveness and organization, and ultimately educational reform. So this really were the primary contributors of the transformation of medicine that led to where we are today. So let me see here, the next slide, urbanization, which again, we already went through. So let me jump to slide 26, but really quick, since we're here already, it really increased the reliance of specialized skills of paid professionals. Remember, urbanization distanced people from their families. They couldn't rely on family as much, and physicians became less expensive because that cost of transportation, now everything was closer in proximity, which increased the access to physicians. And the science and technology, which definitely increased the effectiveness of medicine, became widely recognized. And then we have cultural authority, which is really just the general acceptance of and reliance on the judgment of the members of a profession, was created in the area of medicine. The medical profession's cultural authority is grounded in scientific knowledge, and its authority is legitimized when society accepts its competence in delivering specialized judgments. So the profession's cultural authority is derived from the physician's superior knowledge and expertise in the area of medicine. So the patient becomes dependent on the medical profession's judgment and assistance. The dependent role is further reinforced because laws prohibit individuals from obtaining certain classes of drugs without a physician's prescription, right? And health insurance pays only for treatments rendered for or prescribed by physicians. So reform of medical education was critical in establishing medical training based on scientific knowledge. And advanced graduate medical education was instrumental in establishing the profession's cultural authority because it gave physicians a superior base of knowledge and skills. And again, the growth of science and technology increased that demand for medical services from physicians. And there were a series of groundbreaking medical discoveries during this era. So when we're talking about these medical pioneers, without them, obviously, there wouldn't be any medical advances, no evolution of technology. These medical pioneers kind of pushed forward progress in the area of medicine. But it is important to point out that new and different ideas were often met with hostility, distrust, and contempt. And medical pioneers often deal with, again, opposition and conflict, but due to their determination, they move forward. So first we have Alexander Fleming, the founder of penicillin, and actually with his story on how he found it, it was actually by accident. And it was back in 1928. He was actually investigating a very common type of bacteria known as Staphylococcus that causes boils and can also cause disastrous infection in patients with a weakened immune system. So before Fleming left for like a 2-week vacation, he had a petri dish containing this bacteria culture, and it was actually left on a lab bench and never placed in an incubator as it was intended to be. So somehow in preparing the culture, a penicillin mold spore had been accidentally introduced into the medium. Perhaps coming in through a window, it could have been floating up a stairwell from the lab. I mean, who knows? The temperature conditions that prevailed during Fleming's absence permitted both the bacteria and the mold spores to grow. Had the incubator been used, only the bacteria could have been grown. What's interesting that even, as he came back and he found this mold that he called penicillin, it took him a while to try to replicate it, and he even wrote a paper on it that really didn't take much notice in the 1930s. So it did take a little time, or it was published in 1929. It did take a little time for it to actually, for people to understand the power of penicillin and what a big medical discovery it was. And what's really interesting is each of these pioneers that are listed have a very interesting story. So we have Louis Pasteur that demonstrated sterilization techniques, which and credited for the germ theory of disease and microbiology. Joseph Lister, aseptic technique in surgery is what he contributed. And then the list goes on. I think I have the next 2 slides or so with different names, and you can definitely look them up. They have, I think they also might go into detail in the chapter with some of them, but it's very interesting to read the stories behind these medical pioneers. All right, and next I'm going to jump to slide 34. We're talking about institutionalization. Again, urbanization was a big contributor. Physicians and hospitals developed a symbiotic relationship, and hospitals expanded. Hospitals became indispensable for medical practice. So due to the advances in anesthesia and surgery, it really they created a demand for hospital services. And hospital survival really depended on physicians. In the 1890s, hospitals became more directly related to medical care. And next is really the concept of dependency, which is patients depend on medical professionals' judgment and assistance. Society at large began to expect a sick person to seek medical help. Physicians no longer were seen as tradesmen who you visit for kind of like a quick fix. And dependency was created due to cultural authority. And this idea of valuing the physician's opinion, diagnosis, and treatment. And then we had the cohesiveness in organization, which also contributed to this transformation. Social and economic changes led to greater cohesiveness among medical professionals, and the standardization of education, really created a common core of knowledge among these physicians. And specialization, educational reform, and professionalization led to the need for patient referrals between physicians. Again, there's this dependence and expectation that you do need to be evaluated by a medical professional. So this kind of thinking really came about and was a big contributor in this transformation. And then we had concerted activities of physicians that really represented this creation by the AMA and also created organized medicine here in the U.S. So the American Medical Association has typically opposed national health insurance by labeling it government interference in the practice of medicine and socialized medicine. So for instance, in 1949, the American Medical Association spent about $1.5 million in a successful lobbying effort to defeat President Truman's proposal, because the AMA viewed national health insurance not only as a threat to the individual practitioner, but also as a threat to the hard-won solidarity of the medical profession. And the American middle class has been averse to increased taxes to pay for national initiatives to expand health insurance coverage. So in polls, middle class Americans have expressed support for government programs to help people pay for the medical care they need. But when the same people have been asked about higher taxes to extend health insurance to those that are uninsured, there was a dramatic fall in support. So American beliefs and values really emphasize the principles of market justice. And they really go against the principles of social justice, because individualism and self-determination, distrust of government, and really reliance on the private sector to address social concerns are typically American ideologies. All right, next I'm going to jump to the development of public health. But before that, I just want to touch on the Flexner Report. So the Flexner Report was a report that is actually named after its author, Abraham Flexner, and it was published back in 1910. And he wrote this report for the Carnegie Foundation. At the time that report was written, when the report was written, many medical schools were proprietary schools, operated more for profit than for education. So this report caused those proprietary schools to close. State law was passed which required graduation from an AMA accredited medical school to obtain a medical license, and increased educational requirements, improved the quality of practice, and enhanced cultural authority. And it was due to the publication of this report. Next, we're jumping to public health. So public health is the art and science of protecting and improving the health of a community through an organized and systematic effort that includes education, assurance of the provision of health services, and protection of the public from exposures that will cause harm. In other words, when we're talking about public health, it's what we as society do collectively to assure the conditions in which people can be healthy. Now, the development of this area was really due to the urbanization shift that we discussed earlier in this video. So with these urban centers, there was unsanitary living conditions, inadequate methods of sewage and garbage disposal, limited access to clean water, and long work hours in unsafe industries. And these type of conditions led to diseases. These conditions led to different epidemics. We had yellow fever, typhoid fever, cholera, smallpox, and here is a kind of quarantine poster or public announcement on quarantine regarding typhoid fever. So first we start off with Lemuel Shattuck. So Lemuel Shattuck was actually born in 1793 in Ashby, Massachusetts, and his first career was actually a teacher, and he also moved westward with that wave of migration back in 1817. And he was afflicted with poor health, came back by his family, and he became very active in civic affairs. And he had the strong conviction that collection of data could enhance the ability of government to respond to social illnesses or epidemics. And he was responsible for really outlining the blueprint for the development of a public health system in Massachusetts in 1850. So again, widespread public health decreased the spread of infection, reduced mortality, and increased life expectancy. Next, we're going to touch a little on mental health. So I'm going to jump to slide 50. And really, it was at the turn of the 20th century that scientific study and treatment of mental illnesses called neuropathology had just begun. And in 1946, federal funding was made available under the National Mental Health Act for psychiatric education and research. And then we have the 1960s, where the concept of community mental health was born, and deinstitutionalization became a major thrust of the mental health reform. Next, I'm going to touch very briefly on the health services for veterans, and then go into the birth of workers' compensation and the Baylor Plan. So here we're talking about health services for veterans. The VA is required by law to provide eligible veterans hospital care and outpatient care services that are defined as needed. So the VA defines needed as care or service that will promote, preserve, or restore health. Now, the Department of Veteran Affairs, formerly known as Veterans Administration, built its own hospitals, outpatient clinics, and nursing homes. Next is the birth of workers' compensation. So as the manufacturing jobs became increasingly prevalent, unions were created and they grew stronger. And in order to shield their union members from catastrophic financial losses due to injury or illness, they began to offer various forms of sickness protection, right? And this really started in the late 1800s. So originally this was paid cash for wages lost due to job-related injuries, and then medical care and death benefits were later added to this idea of workers' compensation. And this idea of workers' compensation led to employment-based health insurance. So wage freezes during World War II prompted employers to offer health insurance in lieu of wage increases. It is important to point out, when we're looking at the 1930s, hospital care was largely reserved for the rich. So the system was purely fee-for-service, meaning anyone that couldn't afford those fees relied on charity care in public hospitals. And this included the majority of working people. So this began to change in 1929 when Baylor University offered a $6 per year plan that guaranteed professors up to 21 days of hospital coverage annually. So the Baylor plan, along with prepaid plan covering miners and lumber workers in the Pacific Northwest, would become a very popular known company as the Blue Cross and Blue Shield. But it really shows, the Baylor plan kind of shows how this idea of how health insurance became kind of a more desirable substitute for cash wages. Now, the role of private health insurance was income protection during sickness and temporary disability. And then by 1900, we had health insurance. The primary role was to protect against loss of income again. So disability insurance rather than health insurance. Now, there were a number of factors that contributed to this need of health insurance. So technological factors, economic factors, social factors. And when we're talking about economic, again, unable to predict healthcare needs or the cost for such needs. And then we had the scientific and technological advances, which really made healthcare more desirable, less affordable, and offered new and better treatment. So socially, it became more desirable because of its established healing values. Next, I'm going to jump to globalization. But if you go through the next quite a few slides focusing on health insurance, I provided a lot of detail in each slide, which should really kind of go along with your reading. So let me jump to globalization, and then I'm going to wrap this up. And again, if you have any questions, concerns, do not hesitate to let me know. However, before I jump to globalization, I'm just going to touch on the corporatization of healthcare real quick. Just make sure to go through the whole section of the development of health insurance, Medicaid, Medicare, and I did provide a lot of detail in those slides. All right, so here I am on slide 76. So managed care has become a dominant force for the delivery of healthcare to the majority of Americans. The rise of managed care consolidated immense purchasing power on the demand side. And to counteract this imbalance, providers have consolidated to form large integrated health care organizations. Together, managed care and integrated delivery organizations have corporatized the delivery of healthcare in the U.S. In addition to this, as a matter of survival in an increasingly corporatized system, many physicians had to consolidate into large clinics or form strategic partnerships with hospitals. Consequently, a growing number of physicians have become employees of large medical corporations. And again, I covered this just now, and then I'm going to jump to globalization. So the main economic activities that are discussed in this chapter in the context of globalization in healthcare include cross-border activities. Consumers travel abroad to receive medical care in specialty hospitals that offer state-of-the-art technology to foreigners at a fraction of what it would cost to have the same procedures done in the U.S. or Europe. Physicians and hospitals outside the U.S. are gaining clear competitive advantages because of reasonable malpractice costs, minimum regulation, and lower costs of labor. And we also have telemedicine consultations, which are available to other parts of the world. And there's even foreign direct investment now in health services enterprises. You also have the migration of health professionals. They are moving to other countries that present a high demand for their services and better economic opportunities than their native countries. And we have been seeing that all over on a global level. There's also this need to develop health insurance plans for expatriates. Health insurance face challenges in procuring medical care amid rising healthcare costs worldwide. There's also a demand overseas for medical care by U.S. providers, such as Johns Hopkins and the Cleveland Clinic. So this just kind of gives you an idea of globalization regarding healthcare from what we've covered in this chapter. And again, if you have any questions, concerns, never hesitate to reach out to me. Make sure to go through this video, not just the video presentation, but the PowerPoint presentation in its entirety because it's very long. And I just didn't want this video lecture to get too long. But I have provided a lot of detail when it came to the development of private health insurance, development of Medicaid, Medicare, and the HMO. So just make sure to go through it and read the chapter. And again, any questions, be sure to let me know. All right, best of luck. Take care.